Dr. Moore and Dr. Harris.
Yes.
Are you?
Yes.
You are. Yay. Okay. All right. So everyone, for the next 2 sessions, they're both poster sessions. Authors and speakers will be Dr. Shannon Harris and Dr. Lori PREWITT Moore. Okay, good.
Yes.
Is that a okay pronunciation? Dr. Harris has been teaching the Doctorate of Nursing practice students for the last 6 years and assisting them in exhibiting scholarship through implementing and evaluating the effectiveness of a specific synchronous practice project within an area of advanced practice. As an assistant professor immersed in the University of South Alabama College of Nursing, developing collaborations aligned with her own interests is essential to increasing her own academic growth. As a certified family nurse practitioner, she has worked with pulmonary patients for the past 18 years. Yay, I'm a pulmonary patient. We need good NPs. Her passion is assisting patients with chronic obstructive pulmonary disease to overcome barriers that cause daily breathlessness and poor quality of life. She has participated in the development of a COPD specific inpatient treatment area and a smoking cessation program. She is board certified as a tobacco treatment specialist and a pulmonary educator. Through these certifications, she is competent in coaching smokers through a cessation pathway and to educate COPD patients regarding self-efficacy in management of his or her disease. We have approximately 100 inpatient smokers daily, and it did not take long to realize that we needed more smoking coaches. She applied for a grant and received a $20,000 grant to allow for more COPD team members to become tobacco treatment specialist certified. She has published nursing and smoking cessation articles in peer-reviewed journals. That's Dr. Sharon Harris. Looks good, yes, ladies?
Yes, yes, it does. Thank you so much. Okay, so thank you so much for the great introduction. So I am a pulmonary nurse practitioner. I love anything pulmonary, COPD, pulmonary hypertension, asthma. So I just wanted to tell you a little bit about the smoking cessation team that we started. We go to all-cause 30-day readmission meetings once a month, and COPD was always lacking. We have implemented a few things with timely discharge follow-ups and the smoking cessation program. So the problem was between December 2019 and May 2021, we had 616 COPD exacerbation admits. During that same time frame, we had 117 30-day readmissions. So the purpose of our project was to demonstrate that that an inpatient smoking cessation education would prepare the patient for a serious attempt to quit smoking. So we built a cessation team over the next few months after the scores kept climbing of 30-day readmissions. So we had a physician, Dr. Robert Percy, Lori Moore, myself, and a respiratory therapist. The aim was to explore inpatient smoking cessation strategies to mitigate smoking-related hospitalizations. Our objectives were to use a validated tool to evaluate the level of nicotine dependency, and we selected Fagerstrom Nicotine Dependency Scale for its validity and reliability. We addressed any disparities in the literature and inpatient smoking cessation programs. We wish to foster the growth of cognitive behavior mediations for self-management of nicotine dependency. We wanted to improve the quality of life of all of our COPD patients and save healthcare dollars for the hospital and the community. Some of the background and the significance of the problem is that Alabama is ranked 11th in the nation for active smokers. Cigarette smoking is the leader in preventable disease and death in the United States and is the cause of death for more than 4,800 U.S. citizens. I'm sorry, 480,000 U.S. citizens. That sounds more impressive. The U.S. healthcare system spends greater than $3 million annually on cigarette smoking related illnesses. Our COPD readmission rate was 28%. We did decrease it to 23%, but we wanted to push forward and see what else we could do to get our readmission rate less than 20%. We developed a rounds list of admitted smokers in our EMR, and it averaged 100 smokers a day. We had no inpatient smoking cessation program, nor an outpatient program to help these patients who were interested in smoking cessation. There is a strong push for healthcare legislation to improve smoking cessation programs, and now Medicare is paying for intensive behavior modification for assistance with smoking cessation. Lifetime quit rates for addicted smokers are only 3 to 7% with nicotine replacement therapy and current online smoking cessation programs. So our methodology included, this was a quality improvement project. The setting was our nonprofit 669-bed hospital with 5 ICUs and a comprehensive cardiovascular program. So out of all of the smokers, we did have a lot, only 659 agreed to be in our, we had 659 participants, but only 104 were able to be contacted after the discharge process. It was a convenient sampling. The inclusion criteria was greater than 18 years old and an active smoker, and the exclusion criteria was greater than 18 years old or less than 18 years old and a non-smoker. So we use the Fagerstrom nicotine dependency test. It is in the blue box and it is small. So it consists of 5 questions. How many cigarettes do you smoke daily? How soon after awakening do you smoke? Which cigarette would be the most difficult to give up? The first one in the morning or any other during the day? Is it hard to refrain from smoking where it is forbidden, as in a restaurant or a library? Do you smoke even though you were sick in bed all day? And the last one, do you smoke more often in the first few hours of the day compared to the rest of the day? And that allowed us to score withdrawal symptoms. When we were talking to patients, we found out that more questions could be added in a later study. A question of, do you have to get up in the middle of the night to smoke? Or do you smoke and use your Duoneb albuterol nebulizer at the same time, first thing in the morning? And the next chart, the Harris-Moore smoking cessation chart, we created using the Fagerstrom dependency levels. So for high Fagerstrom score, we offered a Chantix starter pack that could be refilled after 12 weeks, a nicotine 21 milligram patch with tapering instructions, and inpatient counseling. For moderate, we did the same thing. For moderate to low, we did brief inpatient counseling, and for a low Fagerstrom score, we did the same as moderate to low. It was pretty effective. It was easy for other healthcare providers to follow this smoking cessation chart. So let me go over the scores real quick of the Fagerstrom. I should have done this just a second ago. So scores 0 to no dependency, and then 1 to 3 as a low dependency, 4 to 6 as moderate dependency, 7 to 10 as severe dependency, and then we used the smoking chart. So the interventions and the data collection. So the smoking chart was used to determine if the patient wished to have nicotine replacement therapy and our pharmaceutical therapy. As a tobacco treatment specialist, we learned that you can use both Chantix and nicotine replacement therapy patches. If they do smoke 2 packs a day, you can double the patches, 21 milligram patches. A comparison of collected data was performed, including active smoker nicotine dependency and 30-day readmissions for 5 months. The outcome of this project was aimed to reducing less than 60-day active smoker readmissions and increasing successful smoking cessation attempts. So there is a COPD remission results and ANOVA. So during the time frame of October 2020 and February 2021, we had 71 30-day COPD exacerbation readmissions. And then October 2021 to February 2022, we had 27, using the smoking cessation education and prompts for smoking cessation. I did ANOVA, and the F ratio value for the COPD readmissions was 55, and the p-value was 0.00074. So it was found to be significant. And since this project, we were introduced that we received a grant. So the 4 of us were running around trying to do all the education on these on the smokers who were interested in smoking cessation. And we realized that our team was not large enough. So we received a grant, and we were now in the process of, now that COVID is over, they are doing live TTS training where we can get other smoking champions or coaches on our team to expand our program more and further help smokers achieve their goal of smoking cessation and decreasing our COPD readmissions. We are not down to less than 20% yet, but that still is our goal. We are planning an outpatient smoking cessation classes on hospital campus where patients, we can continue the counseling after discharge in the outpatient setting. We have completed a COPD pathway, and it is being rolled out in this month, and it involves palliative care for our COPD patients. There's a piece on smoking cessation that triggers a consult for the smoking cessation team. It encourages further the timely 5 to 7 day discharge follow-up to assure that the patient is has all their medications that they need. It triggers sorry, I've lost my train. A social worker consult to assist that there's no financial barriers to the patient receiving their medications. And it also has an educational piece, a COPD passport that has 6 blocks about COPD education, including using their MDIs, educating them on pulmonary rehab and when they can start that in the outpatient setting. And that all the passport has to be checked prior to the patients being discharged home. And I think that is all. Any questions?
That was fabulous. I have to know, how many of your patients actually admitted to using their duo neb and a cigarette first thing in the morning? I mean, that blows my mind. I'm an asthmatic, and I do everything I can to breathe, and has nothing to do with wanting a cigarette. So I got to know. Yes.
The nicotine dependency is very high. So they score very high on their Fagerstrom. Their carbon monoxide level was very high on admission compared to discharge. And they, there aren't many, there was only a handful, but it is amazing that they would sit in the bathroom on the toilet, smoke a cigarette, and do their nebulizer at the same time because they couldn't breathe, but their nicotine dependency is so severe.
Oh, that's something else. And did you find any real issues with using the Chantix? I've heard of good and bad stories, and I have a son that had a really bad psychotic episode using Chantix. I'm just wondering how many of your folks you found needed something other than that.
There has been 5 or 6 that complain of very vivid nightmares where they're scared to sleep the next night. And so we stopped the Chantix, and then we did a double patch, nicotine patch.
Because I know it was awful when I thought, oh my, I wonder how many you've seen. Anyone else have questions? Because I don't want to hog the stage, but I certainly had questions.
And do we need to check the chat box?
Okay. I'm looking at it. Oh, there we go. I see one. Did your patients in the study voice support for the follow-up phone calls? Did it help them be more accountable or feel supported?
They did. I'm gonna move this chat box. Okay. They did they did enjoy the encouragement, the daily reminders, and we talked to them because some of them said, I smoked more than I did yesterday. It's like, that's fine. We're starting. It's not anything to be upset about. Just start fresh today. Continue to decrease, your cigarettes as, daily as you can tolerate it.
Did any of them say anything about living alone and the cigarette being their only friend?
The biggest thing was coffee in the morning. So they had to change their habits because they could not have coffee without a cigarette. And they were, so we have things like, well, tell a friend to come over and talk to you in the mornings. And maybe you can break your habit that way.
Gotcha.
I was fixing to say something else. I can't remember what it was. Oh, well. Okay. I'm good.
Okay. I'm good too. Anyone else? Questions for these two lovely ladies?
Oh, let me tell you something. So we have a portal that patients can access their medical records. So we're going to try to communicate with them that way. It is time consuming to do the phone calls. So, and it's not a daily thing. We would like daily encouragement through the portal, and where they can ask us questions and we can reassure them.
Right.
Okay, now I'm good.